With the first session of our forenoon session. We will begin with a talk by Dr. Ramasubramanian on the newer developments of TB. I request our chairpersons for the session, Dr. Manjunath Hande and Dr. Kiran Chawla, to kindly take their place on the stage.
Appropriately, we have World Tuberculosis Day, first talk on tuberculosis. The speaker for this session, Dr. V. Ramasubramanian, already Dr. Kavita has introduced. So without wasting any more of your time, sir, I request you to kindly enrich and enlighten us on newer aspects of tuberculosis.
Thank you very much, chairpersons. And over the next 25 to maybe 30 minutes, I shall be talking to you about newer developments in the treatment of tuberculosis. So we may all wonder, what is it TB has been with us for over, thousands of years, and what is it that new which has happened in the last few years that I can tell you about. But believe me, there have been a lot of changes developments which have been happening in the last couple of years at least, and these are pretty mind-blowing. I have no conflict of interest. If you look at the current state, about 1 in 4 people in this world are infected with Mycobacterium tuberculosis. The risk of them developing the disease is about 5 to 10% over their entire life. If you compare that with people who are HIV positive, the risk is amplified to almost 10 to 15% annually. So the risk of a HIV positive person who becomes infected with TB, developing TB, is phenomenally high. 2019 had about 10 million new cases of active tuberculosis. Almost 2/3 of this burden actually is accounted for by just 8 countries. India has the highest TB burden, about 188 cases per 100,000, and also drug-resistant cases burden. The total number of TB patients during 21 was about 20 lakhs. The proportion of multi-drug resistant organisms was about 6.19% among all TB patients, about 2.84% among new, and 11.6% among previously treated patients. So because TB was declared as a health emergency way back in 1993, I think, we are still fighting, and in 2016, the End TB initiative was implemented, and the ambitious goal of this program is by the year 2035, we would have come down on the deaths due to TB by over 95% and the incidence of TB by over 90%. It seems very ambitious to me. So starting with the newer developments, we are looking at the diagnostic changes. These are all the diagnostic tests which are currently probably available. The liquid-based system of TB culture has significantly decreased the pickup of TB in time, about 12.8 days compared to almost 25 days with the solid system. The direct microscopy, though it's simple, easy to use, is not very popular in most countries with diagnosis of tuberculosis. It does not differentiate between viable TB bacteria and dead ones. The WHO approved molecular tests are what I have quoted here: the Expert MTB RIF, the Expert MTB RIF Ultra, the loop thermal amplification test, the TrueNAT tests, the MTB tests, the MTB RIF diagnostic test, and finally the lateral flow lipoarabinomannan test, which is approved for diagnosing TB in urine test for HIV positive individuals. Now, these tests, mainly the expert tests, require continuous power supply and can be expensive. So now we are coming out with the MTB Ultimo and the smaller versions which are portable. We have line probe assays. Though the line probe assays quote a very high sensitivity and specificity, unfortunately in real life situations, the sensitivity for aminoglycosides and ethambutol is probably not very optimal. In general, almost 95% of resistance to rifampicin is from the rifampicin resistance determining region, the RR-DR, but 5% can occur outside this region, and this can sometimes lead to outbreaks. So the whole genome sequencing helps identify all these cases and is also as quick as the shorter ones. The culture-based drug susceptibility testing also has issues. There are some in which the pickup is not very great. Computer-aided detection for chest radiographs and also serum biomarkers, RNA transcripts of patients which are actually signature based on certain proteins also help us in diagnosing tuberculosis. So these, a lot of them are available, but if you look at the susceptibility and sensitivity, still the expert panels do very well. The expert has a 95% sensitivity with 99% specificity. The ultra test loses out a little bit on the specificity, but the sensitivity of the test is improved. And I will tell you in the subsequent slides the current challenges which face with ultra. These are all the ones I mentioned about which have very short turnaround time, probably less than 6 hours time for most, including the Hain first and the second line probe assays. The loop amplification MTB assay is also can be done in a peripheral laboratory and can be done very, very quickly. The TrueNAT, the Indian origin tests are also very, very effective. If you look at the difference between the expert RIF and the expert RIF Ultra, you will find that the limit of detection is significantly lower with the expert Ultra, and that is a reason why it is a far more sensitive test, but it loses out on the specificity. Especially when you look at the rifampicin resistance, the number of probes other than the RPOB gene, there are other probes which look at different copies to identify the risk of, identify the presence of rifampicin resistance, and this sometimes is not effective, or shall I say dependable, if the pickup is very low. So you classify expert MTB RIF as high, medium, low, and very low depending on the quantification, whereas the expert Ultra has a high, medium, low, very low, and also a trace reporting system. So this may add to the problem, because when the report comes as trace detected, the rifampicin resistance is reported as indeterminate. So you're not sure whether it is resistant or sensitive. In this situation, the current WHO advises if you get a trace call on a rifampicin resistance where it is indeterminate for the ultra test, where there is a possibility of a low bacterial inoculum, that is mainly in HIV, in children and extrapulmonary specimens, it should be considered as a true positive. In scenarios where the initial trace call is not for these situations, then it is advised that you do a repeat testing and to then make a clinical decision. Among all persons that test with a trace call, additional investigations may be needed to confirm or exclude rifampicin resistance. So this is a new problem. We are coming across a lot of trace calls with the rifampicin associated with rifampicin resistance for the ultra test, which sometimes may not be feasible to repeat it. So this leads to a lot of challenges. This shows the other panel which is currently available. We are using it in Apollo, the expert MTB XDR panel, which goes on to give you resistance to isoniazid, the fluoroquinolones, amikacin, kanamycin, capreomycin, and ethionamide. These also have a very high sensitivity and specificity, and the turnaround time is very quick. So if we have a person who comes to us with suspected tuberculosis, the gene expert is done, the same evening you get the report, the next morning we are able to get this XDR test, and within 48 hours we are able to determine the resistance. This is very important because it has been shown that 85% of cases with rifampicin susceptible TB do well, whereas probably 57% only of people with rifampicin resistance TB do well. So the more information you have regarding the diagnosis of resistance, the better you're able to treat the patient. Now these are all the current and the future tests which are coming up. We have divided this into the triage test and the confirmatory testing. Triage may include anything from symptom screening using a questionnaire, which is an age-old method, but we are now doing it actively to detect contacts of patients who may have TB. DCXR testing is done through a computer-generated interpretation of the chest X-rays, which is done through a portable machine. A fingerprint prick CRP test from the blood is also being voted as a possible triaging test. It has, of course, several other factors can cause a positive CRP. Host transcriptomics. This is using the host RNA transcripts, usually identifying 3 genes. There is a platform called the Sweeney 3 platform, where by identifying these 3 markers, you're able to at least guess the possibility that there could be tuberculosis. We have tests looking at cytokines, which are again RNA markers, looking at messenger RNA markers. Cough or chest sounds, you use a smartphone with an algorithm and a program to identify what type of cough a person with tuberculosis can have. And this is also been put forth as a triage test. Breath and aerosol testing, where you just catch the breath the person breathes out and look for volatile organic compounds to see whether there is a possibility of TB. The sensitivity is poor, only about 40%, but this could also be used as a triage test in diagnosing the presence of underlying tuberculosis. We have several confirmatory tests, sputum ultra and TrueNAT we have already discussed. There is a blood expert MTB-HR. This is again using the mRNA of TB to identify. This has a reasonably high sensitivity and specificity. Using T-cell activation markers for tuberculosis is also a possible way of confirming tuberculosis. The urine LAMP test, which looks at the lipoarabinomannan, which is a component of the mycobacterial cell wall, typically seen in the urine of people, but the problem is this can be positive if there is non-tuberculous mycobacteria or even certain fungi, which may become positive if the test system is used. Urine, cfDNA, and tongue swabs, looking at aggregated mycobacterial genetic element from the oral secretions, where you don't need to wait for the person to cough up the sputum, just taking a swab from the tongue also is very, very attractive. So these are all the newer diagnostic tests which are helping us probably zoom in. You know that almost 95% of TB is already being transmitted to others by the time a person is diagnosed. So the sooner you diagnose, the better the chance of controlling TB. There are 4 interventions. 1 is early diagnosis and identifying drug resistance. 2 is ensuring adherence to treatment with anti-TB drugs. 3 is robust contact tracing, where you follow up all the patients who have been exposed to the index case, and also screening high-risk people. These are the 4 main mechanisms by which you try to identify TB early and treat TB. So these are very important if you are looking at trying to eradicate TB in another 15 years. Now, the summary of the WHO recommendation on drugs, this is the latest one which has come up from WHO. The new treatment of patients with TB, they should receive a 6-month course of HR, ZD for 2 months and HR for 4 months. I think this is well established. If INH susceptibility is known, then we continue, and if it is susceptible, we continue with only HR. If it is not known, HRE is advised for the 4 months. This 4 months of a continuation phase should be expanded to 7 months if the person has persistent culture positivity after 2 months, there is a large cavity, if the person has resistance to pyrazinamide or you are not able to use pyrazinamide. In that situation, it is recommended that you continue the continuation phase, which is 4 months, and increase it to 7 months. Wherever feasible, the optimal dosing frequency of patients should be daily, so no longer intermittent therapy is recommended. All patients with drug-susceptible TB, the use of thrice-weekly dosing is not recommended. Fixed dose combination makes it easy for the person to have the medicine, so that is what is in vogue now. And new pulmonary TB patients treated with regimen containing rifampicin throughout the treatment, if positive sputum smear is found at completion of the intensive phase, the extension of phase is not recommended. So these are the current recommendations from the World Health Organization. But moving forward, we are looking at shorter courses, because it has been very clearly shown that shorter courses improve adherence, and if you're able to get a regimen which finishes sooner, the chances of clearing TB is more promising. So this was a recent study where they used a 4-month rifampicin regimen with or without moxifloxacin for tuberculosis, and it was found that this regimen was non-inferior to standard 6-month regimens in the treatment of tuberculosis. So these are what I'm going to say in the next few minutes are all studies which are in operational conditions prove very, very successful. But whether they will be able to be applicable in real life, I think we still need more evidence. So this study basically added that was a recommendation for using a 4-month regimen containing 8 weeks of daily treatment with rifampicin, isoniazid, pyrazinamide, and moxifloxacin followed by another 9 weeks of daily treatment with rifampicin, INH, and moxifloxacin. So this has been approved and recommended by the World Health Organization. Other shorter regimens for TB, typically in the treatment of children in India and Africa, was also published. This was last March, a year ago. People aged 12 years or older with drug-susceptible TB may receive a 4-month regimen of rifampicin, isoniazid, moxifloxacin, and pyrazinamide. This was a new recommendation. And in children and adolescents between 3 months to 16 years with non-severe TB, where there is no suspicion of drug resistance, a 4-month treatment of, again, HRZE for 2 months and HR for 2 months also seems to be non-inferior. So these are, in the last year or so, these recommendations have been put forth to suggest that in this situation, that is, as I repeat, non-severe disease where there is definite susceptibility, you can probably get away by using a 4-month regimen. This was a paper published, I think, only 2 weeks back in the NEJM, 2 or 3 weeks back. The Truncate study, which looked at the treatment strategy for rifampicin susceptible tuberculosis. These were the various regimes which were used. Standard treatment, which was rifampicin, isoniazid, pyrazinamide, and ethambutol for 6 weeks, was compared with an 8-week course, that is a 2-month course. You look at the various options given. It's okay. The first one was rifampicin and linezolid were the newer drugs added. The second one was, which is high dose. Second one was high dose rifampicin along with clofazimine. Third one was rifapentine with levofloxacin and linezolid. And the fourth one was bedaquiline and linezolid. Apart from that, the main frame included isoniazid, pyrazinamide, and ethambutol in most regimens. Amongst these 4 regimens, the regimen containing clofazimine was stopped early because there was problems importing the drug in 2 or 3 countries where it was done, so that regimen was not continued. And the regimen which included rifapentine and linezolid and levofloxacin was also discontinued because there was a very high pill burden, which means actually only the standard treatment was compared with the rifampicin, linezolid, and bedaquiline, linezolid arms. And it was found that it was not inferior to the standard regimen, even though the standard regimen performed much better than the shorter regimens, but the outcomes were not unfavorable when you compared it with the standard regimen based on the statistical analysis. Moving on to drug-resistant TB, we know that the drug resistance for tuberculosis has doubled in the last 5 years. If you look at drug-resistant TB deaths, it contributes to almost 1/3 of all deaths related to antimicrobial resistance. So when we talk about AMR, we are not talking only about gram-negatives and gram-positives, we are talking about tuberculosis also. And this has a severe economic consequences. You'll see the huge burden which is seen in the Indian map over India. And the recent developments to do with drug resistance are, number one, the WHO modified in 2019 the classification of drugs used to treat drug-resistant TB. So group A includes quinolones, bedaquiline, and linezolid. Group B, clofazimine, cycloserine, or terazidone. And group C, which includes all the other miscellaneous ones, ethambutol, pyrazinamide, delamanid, imipenem, meropenem, amikacin, ethionamide, prothionamide, or PAS. So this is the new classification upon which any kind of recommendation is made. The second change was the definitions of drug resistance TB also changed. When we called rifampicin resistant tuberculosis, it implies only resistance to rifampicin. When we say MDR TB, it implies resistance to rifampicin and isoniazid. When we say XDR, that is resistant to isoniazid and rifampicin, any fluoroquinolone, and either bedaquiline or linezolid or both, which means all your group A drugs are knocked off. And when you say pre-XDR, which is a newer classification, which means this is MDR, that is rifampicin plus isoniazid, plus any fluoroquinolone. This classification is based for ease of treatment modalities when you apply the treatment. This is a very good, nice article I would recommend all of you to look up. It's a very small, it's only a 6-page article which came in Lancet Respiratory Medicine Commission. And even last week when Dr. Kirtan Dheda gave the talk here in this thing, Manipal, he commented, and I found this very, very useful in looking at the approach to treatment of drug-resistant tuberculosis. So if you look at the current medical management of MDR-TB, these are the points which are raised. One, the route. We would prefer oral route because even though conventionally we have been using second-line injectable aminoglycosides, it has been found that they are associated with more side effects. In fact, capreomycin and kanamycin give worse outcomes than when you use amikacin. Earlier, when I was learning, I was told that amikacin increased cross-resistance, so do not use amikacin. So we used to use a lot of, after streptomycin, we used to use Cana or Caprio, but no longer recommended. We go for amikacin, and that to put a PICC line in, monitor the ear functions and vestibular toxicity and nephrotoxicity. So oral drugs are preferred. What is the optimal number of drugs? The WHO says 4 drugs. The CDC says 5 drugs for the initial phase. The 4 drugs should include at least 3 of the group A drugs plus 1 of group B drugs at least, provided they are all sensitive. The reason why CDC says 5 drugs is because inevitably one of them get dropped off due to toxicity. So CDC says it is safer in a situation where there is a possibility of toxicity and you're not very sure about the resistance profile for all the drugs used, better to use 5 drugs. The choice of the drugs, we are now looking at more and more, including linezolid and bedaquiline in the initial phase. Addition of both these drugs are associated with a good response when you shorten the treatment duration. So bedaquiline for 6 months or even 9 months. Linezolid similarly can be used. Along with that, you make sure that you used first group A drugs, and if you're able to use only 2 of them, add at least 2 or 3 of the group B drugs. And if you're not able to come up with a total of at least 3 drugs which are susceptible, you add drugs from the group C also. Duration, there's still a lot of confusion. I'll very briefly run through the various papers. We are looking at treating MDR-TB for 9 months or even less now with the current regimen, which seems to have good outcomes. You need drug susceptibility testing. When you're using drugs like imipenem and meropenem, make sure you use clavulanic acid also. So you need to add co-amoxiclav along with it. Studies have shown that there is a drug gradient even on the cavity wall. So there are a lot of issues with PKPD when you treat even for pulmonary disease. And the challenges will include, we are not sure how long to continue after conversion, typically how long to use linezolid, what is the dose we use. There are a lot of studies comparing 600 BD with 600 OD. What biomarkers do you follow? What about delayed diagnosis? Because a lot of these studies, especially when you're using a purely oral regimen, a shorter regimen, you need to ensure that the person has only pulmonary tuberculosis, has sensitivity to fluoroquinolone, and does not have very extensive disease, and has not used any of these agents for more than a month previously. So all these conditions have to be met if you're using a completely oral short-term course. And this is the compilation of both the ATS, CDC, ERS and IDSA recommendation. You'll see for if it is rifampicin resistance, treat as MDR-TB. If there is INH monoresistance, you use rifampicin, pyrazinamide, ethambutol and fluoroquinolone for 6 months. Can discontinue pyrazinamide after 2 months. Fluoroquinolone only required in patients with extensive disease. For MDR-TB, always use a quinolone with bedaquiline, linezolid, clofazimine and cycloserine if possible. These are a little old. There are newer studies which have said this may not be needed. Consider delamanid, pyrazinamide, ethambutol, and third line, ethionamide, prothionamide, or the carbapenems. So these are the various regimens. This was an article which came last year. So a lot of the studies were still under evaluation, but we have got the reports, the final end results of various. So I'm just going to spend about 30 seconds in each of them. The practical clinical trial, which was an eye-opener where they looked at a 6-month, these are all for drug-resistant tuberculosis, a 6-month regimen including bedaquiline, pretomanid, and linezolid plus moxifloxacin, what is fondly referred to as a BPAL-M regimen. So this was found to be non-inferior and it was found to be very safe. There was a 24-week oral regimen for tuberculosis, which contained only bedaquiline in this situation with linezolid and Pretomanid. This was found that the treatment with BPAL-M was more effective and had a better safety profile than the standard care. There are several regimens, mainly from South Africa, have been looked at. Shorter regimen for rifampicin tuberculosis, which was susceptible to fluoroquinolones and aminoglycosides. So this was the Stream 1 study, which was the Bangladeshi regimen, where they used the injectable second-line agents, but shortened the duration of regimen to less than a year. So this was followed by the Stream 2 study, where they were looking at a 9-month regimen of rifampicin for rifampicin-resistant tuberculosis, and they found that the shorter regimen, which included bedaquiline and linezolid and a fluoroquinolone used for 9 months, actually did very well. So both bedaquiline-containing regimens, a 9-month regimen and a 6-month regimen with 8 weeks of second-line injectable drugs, was superior when compared to the 9-month injectable regimen. So this 9-month injectable regimen, which was the Bangladeshi regimen, which had initial 16 weeks of injectable aminoglycosides, was actually found not to be effective, especially in HIV patients, and if with regard to toxicity, this was not recommended. I will skip these. This is the highly resistant tuberculosis, where a combination of, again, bedaquiline, Pretomanid, and linezolid used for 6 months showed good results. I repeat, these are only in operational conditions. These are not yet recommended for treatment. So this was again from South Africa, Pretomanid, bedaquiline, and linezolid, which are now coming up as probably very, very strong agents in the treatment of MDR-TB. This was a study again from South Africa, an all-oral bedaquiline-containing regimen, which looked at patients in the bedaquiline group experienced significantly higher rates of treatment success at 24 months. This finding supports the use of short bedaquiline-containing regimen in eligible patients. Lastly, an all-oral 6-month regimen for MDR-TB, the next study, concluded that compared to the traditional injection-containing regimens, an all-oral 6-month course of levofloxacin, bedaquiline, linezolid-containing regimen was associated with significantly improved 24-month outcomes. So this is where we are heading. The adverse event-related treatment discontinuation in the safety population was more common in the standard of care arm. However, grade 3 adverse events were more common in the interventional arm. So again, we need to finalize the dosing of linezolid. We need to finalize the duration of treatment of bedaquiline. And this is the latest 2022 update by the WHO. Just spend about 30 seconds looking at this. The options available for MDR-TB, XDR-TB, pre-XDR-TB is given. Please remember, if there is extensive TB, you need to use a more prolonged course. You can't use a 6-month course for treatment of MDR-TB. So this basically summarizes our current knowledge and probably how our approach has to be in the treatment of drug-resistant tuberculosis. And the dosages include bedaquiline 400 milligrams once daily for 2 weeks, then 200 milligrams 3 times per week afterwards. This is currently available in the government programs, and I've been told that if you liaise with them, even private practitioners can use it. I don't know how it is in Manipal, but in other places we may have to refer the cases, and you can probably have a joint care subsequently. Newer drugs, 16 drugs are in the fray, and this Telacibec, the last one mentioned here, shows a lot of promise. The future, the routes of delivery, we are looking at inhalational drugs. We are looking at host-directed therapy using adjuncts like vitamin D, everolimus, and probably other agents can be used, which still don't show too much benefit. We are looking at not only directly observed therapy, but video observed therapy as a possible intervention to ensure better adherence. We are looking at prophylaxis. I'm going to spend another minute on prophylaxis and vaccination. This is again probably the way forward. BCG vaccine has shown to decrease the incidence of miliary TB and meningeal TB by 85% in children under 10 years of age. But these 3 vaccines, the first MTB vac is used as a pre-exposure vaccination, but the VPM and the M72 are showing a lot of promise as post-exposure, that is in people with a positive MANTO, people who have TB infection, to prevent them from developing the disease. This is from yesterday's Times of India. After pilot projects in Pudukkottai and Tiruvallur, TB preventive therapy to be expanded to all districts in Tamil Nadu. We are now looking at As I said, by the time a person with pulmonary TB is diagnosed, he's already transmitted it to a lot of his family members. So you need to enter where before they start, they are in subclinical phase, before they develop disease due to tuberculosis, you have to intervene. So the WHO guidelines are typically looking at young children with regard to HIV, everybody with HIV, with regard to non-HIV people, household contacts, regardless of HIV status, children under 5 or children more than 5 with people who had with family members who have confirmed TB or in high-risk population, you need to specifically screen, ensure that they do not have active disease before you put them on prophylaxis. These are the various regimens: 6 months of isoniazid, 3 months of rifampicin and isoniazid weekly, rifampicin and isoniazid daily for 3 months, rifampicin for 4 months, rifampicin plus rifampicin for 1 month. This seems very promising but has not been yet validated, and isoniazid, long course. All this are found to be equally effective. What about MDR-TB? Prophylaxis in manto-positive patients who have been exposed to MDR-TB, fluoroquinolone with another drug for 6 to 12 months is what is currently recommended. Lastly, challenges in India, testing strategy, availability and affordability of drug susceptibility testing, the extensive use of fluoroquinolone in the non-TB arena, availability of bedaquiline, clofazimine sometimes goes out of stock, the low body weight increased. It's been shown that Indians have a higher risk of hepatotoxicity due to ATT than the Caucasians, and follow-up mechanisms. So lastly, we are now looking at customized therapy, and the way Google is going and the GPT is going, this is how we may end up. We had to amputate above the knee. So I think we have to step back. We are having a lot of developments, but still, whether this can be applied in the real world is yet to be seen. Thank you.
Thank you, sir. Thank you, sir, for giving that great insight into that topic. So just one question from my side before I go to the house here. So you have shown in the diagnostics, sir, that CF-TAP, that one test, is it related to cystic fibrosis?
No. This is just T cell activation. I'm not sure what that CF means, but it's T cell activation basically.
No. Okay, so I was just thinking because
no, it's not even T cell activation.
One study I read that there it was related to cystic fibrosis. CF,
no, CF-DNA, that's different. The TAM is the T cell activation. This is urinary, this is extracellular DNA of mycobacteria.
DNA, okay. So thank you. So it's open for the house now, so any question? Yes. Mike.
I have a bunch of questions actually. I'm cell-free DNA, that is CFDNA. So the question is, we used to use, we always told that bedaquiline has a high half-life, longer half-life. That is the reason why we stopped bedaquiline at 6 months and we are giving a long MDR regimen. Now all these trials which we are doing, we are stopping everything abruptly. So do you think it is a concern? Will it lead to bedaquiline resistance?
That is why I said that we are still, all this still in operational situations where as part of, study conditions. How much of this is entirely applicable in the real world, we have to wait. These have all happened in the last 2 years. I think we are still too early for us to use this and say this will work in real life. We don't know.
So another question is, when we are using this Expert Ultra, sometimes we find very rarely but APHC and FABG mutations for INH. So whether, how to one case we had a APHC mutation when we saw the phenotypic susceptibility, it was INH sensitive. So what should I take it as, sir, INH sensitive, resistant?
It's a very, very difficult call. As I said, these trace calls are adding so much confusion because it's very easy to say repeat it, but in real life, again, in practice, you cannot repeat it. So you need to take a call, a clinical call. So I don't think there is a right way or a wrong way. I think with more experience, we should probably be able to define this better.
Sir, one more question was about the way we are doing studies. If we see a Cochrane review, which was published in 2017, where definitely a fixed dose combination was associated with high relapse rate, which is 30% higher than a individual regimen. But none of that is reflected in any other guidelines, and we always say the FDCs are preferred over individual drug regimen. If I am a clinician, if I say if I tell the patient that there is a high risk of relapse, 30% higher risk of relapse, probably nobody will prefer FDC regimen, but that is not reflected in any of the guidelines or any of the discussions we ever had. And the another trial, which is a short course rifampicin moxifloxacin trial, if you see the per protocol analysis, the short course regimen was inferior. It was non-inferior, but it was inferior because the margins are always falling in the inferior side. Again, in that particular study, it was never reflected that in per protocol analysis, it is actually inferior but non-inferior. But non-inferior, but it is inferior. Yeah. So these are the things which are like not reflected in the studies, and we are saying the short course regimens are great. I don't know, sir, how it will translate. I wish.
Okay. If probably you've been doing medicine as long as I have been doing, you realize that everything goes in waves. Whether it is the role of steroids in sepsis, whether it is the role of prophylactic drugs, whether the role of serum levels, one paper doesn't make a book. This is something which evolves. You may find that after 2 years, we may say that this short regimen which showed so much of promise is actually leading to a lot of relapse after 3 years. We don't know. So that is why we keep on insisting you need to use clinical judgment. We have come up with guidelines, not extensive. Fluoroquinolone sensitivity should be there. They should not have been exposed to it before. But in spite of all this, there are a lot of variables. And statistics, you can go around with statistics to suit your needs. So no, I don't know. I don't think we will know at least in the next couple of years. But these are overall regimens which seem very, very promising. Even the latest, this truncate study we discussed in our journal club and found that, it was not inferior, but when you look into it, everything says otherwise. You read up the truncate study. So, I'm totally confused. How can you say, nothing happens, but still you say, oh, it works as well as the others. So, lot to learn.
So with your permission, may I add to that gene expert?
Yes, please.
So for that gene expert, that question he has asked, that gene expert and phenotypic DST. So in my knowledge that, because I am a microbiologist by the profession, so the genotypic or all the genomic way when we detect, that is just the presence of mutation we are detecting. But phenotypically, which is kept gold standard also, because that is the expression of the gene. So if we have both the things done, then we should go with the phenotypic. So because that is the best way to go for the treatment regimen. That's what we learn. So.
That is very well said, but to make it a little more complicated, we find that, okay, it is not expressed. Maybe the gene is present, it is not expressed, so phenotypically it is sensitive. But once it is exposed, the drug is exposed, how do you know this is not going to activate? We don't know. So, as I said, you can argue both ways. But as of now, I agree with ma'am saying that if phenotypically is susceptible, go ahead.
Thank you, sir.
Thank you.
You have covered all the aspects of tuberculosis which are important for the clinicians, and I thank the audience for giving the ovation he required.
Yeah, I now request the chairpersons to hand over a memento to our speaker.